Now, welcome to part 2 of my presentations on the coronavirus, and I will discuss with you the clinical pictures of COVID-19. A very interesting point about the coronavirus causing COVID-19 is that there is a huge variation of severity. It can be from asymptomatic till death, and asymptomatic means no symptoms. It is indicated that up to 30–40% of the infected patients remain asymptomatic. It is of course difficult to be completely sure of this because you can have insufficient follow-up, but there was a case of a cruise ship where were 712 confirmed cases and 50–58% of those contaminated cases remained asymptomatic. It becomes also clear that the younger you are, the more likely it is that you will be asymptomatic. However, 50% of the asymptomatic patients may have abnormalities seen on the CT scan of the thorax with ground glass opacities of the lungs. So it means that there is some sort of inflammation caused by an infection by the virus is taking place. And perhaps these patients are in fact a little bit pre-symptomatic, but pre-symptomatic with minimal symptoms. The incubation periods is estimated to be between 3 and 12 days, and the median is 5 days. So that means that half of the patients have their symptoms within 5 days and the other half have it after 5 days. Now, which kind of symptoms will they have? Well, it will be symptoms like rhinitis, a headache, a cough, which can be accompanied by a very sticky, vicious phlegm, pneumonia, myalgia, and fever. Also, GI symptoms can be present, from nausea to diarrhea or just some abdominal discomfort. And a very specific sign is the anosmia or the dysgeusia. Anosmia means that you have no smell, and dysgeusia means that you have an altered smell. So it means that instead of smelling coffee, you think that you are standing before a gas station and smelling gasoline. Short of breath with tachypnea is an important possible symptom, like myocarditis. Patients can develop renal failure and even multiple organ failure. COVID-19 can cause death, as I outlined before, and the question is, of course, how big is the case fatality rate? And this has all to do with the numerator and the denominator. If you do not make sufficient diagnosis, then you will not know what is exactly the case fatality rate. So you need to know the number of deaths. Well, that might be clear, but then the number of cases is not always completely clear, especially when you have a lot of asymptomatic patients. Another thing that is very important is that people die at the end of your life. And you also have to die of something, and you can die of flu, and you can also die of COVID, especially when you're close, very close to the end of your life. So in that case, COVID or a flu can just end the life a little bit earlier or earlier. If we just calculate the case fatality rate, based on what I indicated in my first presentation, global deaths divided by the global cases, we come to a case fatality rate of 2.1%. And this is very probably an overestimation of the case fatality rate. If we look at Israel, there were 435, almost 36,000 cases, 436,000 cases, and over 3,000 deaths, which comes to a case fatality rate of 0.8%. This is a very interesting study published in the New England Journal of Medicine, in the Iceland study, where they measured antibodies in over 30,000 persons. And the conclusion was that the results indicated that antibodies against SARS-CoV-2 did not decline within 4 months after diagnosis, but they estimated that the risk of death from infection was 0.3%. And 44% of persons infected with SARS-CoV-2 in Iceland were not diagnosed by a PCR, indicating that they had no complaints. So in this case we come to a case fatality rate of 0.3%. This was published in November in the JAMA, where you can see the COVID-19 mortality in several countries. And in the upper part of the table you can see the countries with the low mortality, like South Korea, Japan and Australia. And the lower part of this table you see the countries with the high mortality, such as the Netherlands, France, and many European countries, as you can see. And the COVID-19 deaths per 100,000 can be as high as 36 in the Netherlands and 60 in the United States and 86 in Belgium, as you can see. Another measure to look at the deaths caused by coronavirus is to look at the excess all-cause mortality per 100,000. And then you compare the number of deaths of this year with the period of 5 previous years. And you can see again that you have countries with a moderate mortality, like Norway, Denmark, and countries with a relatively high mortality. And as you can see, different rows with the excess cause mortality per 100,000 since the start of the pandemic, and also since a later date. And again, you can see there is a very remarkable difference between the different countries. Now, how should we see this case fatality rate? And I put it into perspective and compare it to other infectious diseases, as you can see here. Now, rabies is a well-known disease, and as you can see, it has a case fatality rate of 100%. Once you have signs of rabies, and then the mortality will be 100%. Ebola virus, also well known, is also much worse in terms of case fatality rate. As you can see, 83 to 90%. And luckily we now have a vaccine for that. A seasonal influenza, as you can see, it is estimated to be as high as 0.002%. So this is very low. But in different countries it will depend very much on the age group of the patients involved. Now have a look at the yellow fever, which is also a viral disease. It has a case fatality rate of 7.5%, and that is why in some countries where it is endemic, there is an obligation to have a vaccine against this. And the Spanish flu in 1918 had a case fatality rate higher than 2.5%. And this was especially caused by deaths of younger people. Now, the coronavirus disease 2019, Covid-19, is estimated to between 0.23 and 1.15% in this table that I picked from Wikipedia. And I think the truth is approximately approximately 0.3%. Risk factors are well recognized. Well, the first risk factor is age. The older you are, the higher the risk for having severe disease. And the case fatality rate in octogenarians or older is 15%. And the hospital admission rate for young people is less than 1% for people between 20 and 30 years of age. Well, in terms of diversity, it is not a very fair disease. Being a man is a bigger risk, and there are also other genetic factors have been recognized, like the blood group. For instance, blood group A is associated with a higher risk of mortality, whereas blood group O is associated with a lower mortality. Comorbidity also plays a role. Well-known comorbidities like diabetes, congestive heart failure, chronic obstructive pulmonary disease, hypertension, obesity, smoking, and kidney disease, previous chronic kidney disease, will increase the risk for death. Well, these are figures coming from the Netherlands, where the mortality of ICU patients is indicated. And as you can see, there is a very clear increase of mortality risk with an increase of the age, showing that patients between 80 and 85 who have been admitted to the intensive care, so that is already a selection group, a selected group, has a mortality of over 65%. And as you can see, also, men do not have only a higher risk of getting severe disease, their outcome is also worse compared to women. There are some indicators of worse outcome, like elevated inflammatory markers, CRP, IL-6, and also TNF. High D-dimer is an indicator, clotting, activation, lymphopenia, and, well, this speaks for itself, multiple organ failure. When you have multiple organ failure, it is of course an indicator of a bad outcome. Other factors that play a role in the disease severity are the socioeconomic factors, and perhaps there are some indications for that hypovitaminosis D. Other factors determining the disease severity is the viral load. And this is of course not measured and indicated in each patient, but it becomes quite clear that the viral load of the contamination plays an important role in the course of the disease. Other complications we can discuss are pulmonary thrombosis in ICU patients, up to 20 to 40%. And I specifically speak of pulmonary thrombosis and not of pulmonary embolism, because it becomes clear that the clots are formed within the blood vessels in the lung itself. However, other thrombotic complications also occur, like venous thromboembolic disease and a cerebrovascular accident. Cardiac injury is an important thing that can be seen during COVID-19 related to arrhythmias, myocarditis, and cardiomyopathy. It has been demonstrated in up to 33% of the ICU patients encephalopathy is seen. Long-term consequences, well, we still have a lot to learn, of course. But it becomes clear that a high percentage of the hospitalized patients have some complaints, and we need, of course, further documented data and comparison with other diseases like influenza. But symptoms like dyspnea, fatigue, chest pain, cough have well been described, as well as psychological and cognitive problems. And post-traumatic stress syndrome is reported in up to 24% of the hospitalized patients. And even in mild disease, there is a significant proportion of patients that did not return to work within 3 weeks. This is a very recent study published on January 8. As you can see here, looking at the 6-month consequences of COVID-19 in patients discharged from hospital, and 76 patients still had symptoms after 6 months with fatigue, muscle weakness and sleep difficulties. 23% suffered from anxiety. 23% had reduced walking distance in 6 minutes. So the exercise capacity is clearly reduced, and pulmonary function abnormalities were present in severe cases in 20%. So this is not negligible at all. And here I come to the end of my presentation of part 2, and I invite you very much to watch part 3, where I will discuss the transmission of the virus, and I thank you very much for your attention.